We have started recording already. Maybe a bit too early. Liz, can you?
Between left atrial fibrosis and other parameters of the left atrium. We didn't find any correlations with volume measurements. We did find a weak but significant correlation between left atrial fibrosis and left atrial reservoir strain and conduit strain, but not with contractile strain. When we looked at the right atrium, we found a mean fibrosis value of 28.6%. And again, only a significant correlation was found between right atrium fibrosis and right atrium reservoir strain. Then we wanted to compare left atrial remodeling parameters with right atrial remodeling parameters. And I can show you that here in this figure. And we found that the maximal atrial volume index was very strongly correlated from left to right, as well as atrial reservoir strain, contractile strain, and conduit strain. This strong correlation was not found for the emptying fraction. The most interesting finding we found when we looked at the correlation between left and right was the correlation between right atrial fibrosis and left atrial fibrosis, as you can see here in the figure in the middle. We found a very strong correlation with a coefficient of 0.88 and also very significant. I'm just going to go back. Sorry. Then we looked at these remodeling parameters, so the left and right remodeling parameters in relation to the atrial fibrillation recurrence after ablation. A total of 39% of the 110 patients had AF recurrence, which was 36%. So in this table, you can see we created two groups, one group with recurrence of AF and the other group was without recurrence. And the orange marked ones are the significant differences between these groups. So the interesting thing here is we see that the left atrial volume and left atrial strain measures were significantly different between those groups, whereas this was not the case for the right atrial volume and right atrial strain measures. There was a trend towards significance regarding the percentage of patients with persistent AF. So there was a higher percentage of patients with AF, persistent AF in the recurrence group. But again, this was not significant. We didn't, interestingly enough, didn't find any significant differences in recurrence between the left atrial fibrosis. So the higher the fibrosis, the higher the recurrence was. We did not find this relationship, and neither did we find this relationship for the right atrial fibrosis. What we then did was we created two groups, a high fibrosis group and a low fibrosis group based on the median. So in this figure here on the left, you see that the high fibrosis group in red and the low fibrosis group in blue, they did not have any significant differences when we look at arrhythmia-free survival percentage. And the same goes for the right atrium. When we performed a multivariable regression analysis, left atrial contractile strain was independently associated with AF recurrence. So to summarize, this study showed that atrial fibrosis assessed by LGE CMR was found in equal amounts in the left and right atrium. And also the degree of left atrial fibrosis had a very strong correlation with the degree of fibrosis in the right atrium. But this amount of fibrosis was not predictive of atrial fibrillation recurrence after ablation. The right atrial remodeling parameters did not significantly differ between the recurrence group and the non-recurrence group, where this was the case for the left atrial remodeling parameters. And especially left atrial contractile strain was an independent predictor of AF recurrence. When we look at other studies, we found another study who also assessed this relationship, and they also found a linear relationship between left and right atrial fibrosis burden. And this suggests that atrial fibrillation might promote structural remodeling in both atria, leading to biatrial pathology. Also, histological assessment contributes to this idea. In one study, they did quantitative measurements of fibrosis, and they found also comparable amounts of fibrosis left and right. So this hypothesizes that not only left atrial fibrosis, but also right atrial fibrosis can potentially serve as an arrhythmogenic substrate for AF maintenance. But when we look at the clinical implications, we didn't find a relationship with recurrence rate after ablation, and therefore we could argue, or we could think that atrial fibrosis may be a manifestation of atrial cardiomyopathy, but not the hallmark driver of AF. Next to that, the diagnostic accuracy of LGE CMR to detect atrial fibrosis might be suboptimal. A recent histological study looked at fibrosis, but then specific endomysial fibrosis, which means within muscle bundles. And they found a very strong correlation with AF complexity, while this relationship was not there for a total amount of fibrosis. With LGE, we assess the total amount of fibrosis. So this might be the explanation why we have a mismatch between fibrosis and AF recurrence. When we look at the limitations, obviously there are the general CMR limitations as like differences in CMR acquisition, while this is not the case for assessing the differences between left and right, as this was in the same patient, so the same circumstances. Next to that, there's currently no complete agreement on which threshold to use for fibrosis. We used 1.2, but there has not been an histological validation on this value. Next to that, because the atrial wall is so thin, we used a 2 voxel thickness, and sometimes the endocardium is even thinner than that. So that's why partial volume effects could not always be excluded, although we try to avoid them as much as possible. Also, we use the same technique we used for the left atrial fibrosis as for the right, and this has not been as established yet. This could also explain the strong correlation because we use the same technique. The right atrial volumes and strain were only calculated from the 4-chamber view, while as left atrial volumes were calculated from 2 and 4-chamber views. That's why the RA remodeling assessment might be less accurate than the left atrial assessment. And we didn't have any continuous monitoring of AF, so that could have led to an underestimation of AF prevalence. So to conclude, biatrial fibrotic remodeling is present in patients with AF, and the amount of left atrial fibrosis correlates strongly with the amount of the right atrial fibrosis, and therefore it could be an expression of disease state, but larger studies are needed to investigate the biatrial interplay, fibrosis development, and potential role in arrhythmogenesis. Thank you.
Thank you very much, Julia. As usual, if you have questions, so anybody in the audience, just post them in the meeting chat. So I have to say, the whole topic of atrial parameters, including tissue and function, and AF is a pretty complex one. It's sometimes not easy to disentangle all the different questions that are associated with that. But of course, one of the key questions always is how and you, Parsha, you mentioned that, how confident can we be in our methodology to assess the atrial wall, because it's thin, and we only have, as you said, you also had just basically a biplanar view of the atrium, of the atria, and the atria are do not necessarily have a geometrical shape that if your axis is slightly off. So how confident do you think, or did you feel when you did the evaluation? So a question to you and Luke maybe. So with respect to identifying the wall, making sure that you do not include other tissue, and especially for the late enhancement, which has been a huge discussion, is the number of pixels we actually have enough to comment on tissue characteristics?
I can comment maybe first, and then Luke can add anything. So what we did was we used the MRA images because the contrast is bigger between the blood pool and the endocardium. So by doing that, we hoped to better be able to define where the actual endocardium was. And then we co-registered that with the LGE images. So that was one way to try to avoid it. But obviously you cannot avoid it entirely, I think. Maybe, I don't know if Luke wants to add anything to that.
Well, first, thank you for the invitation for presenting our article in this journal club. And yes, indeed. So what Julia said is that we use the MRA to segment the left and right atrium. So we hope to avoid or to stick to the atrial wall as much as possible to get a good segmentation. But indeed, it is difficult, and the atrial wall is thin and is not. The thickness of the atrial wall is variable across the atrium. So we used a 2-pixel wall thickness, which is not always optimal, I think. And I think good to add is also that it is assumed that the left atrial late gadolinium enhancement reflects atrial fibrosis, but we cannot exclude that there are any influences of edema and inflammation that can also result in a higher signal intensity in the atrial wall. So we assume it reflects fibrosis, but that's not. It's also not exclusively reflecting fibrosis.
Okay. Thank you very much. So in the interest of time, we'll have to just very quickly address the 2 questions that we have there. One, was there pathological confirmation of CMR-based atrial fibrosis? I think not. Julia, Luke, do you want to comment?
Yeah, there are some studies who evaluate the left atrial fibrosis assessment, but we didn't. No.
Yeah. Okay. And then what was the CMR protocol for late gadolinium enhancement images in the left atrium? Because we know that, for example, inversion times, the found inversion times are different from the right ventricle, the left ventricle, partially due to the thin wall, but that may also relate to the atrium. So the protocol, is it in the paper, so we can just refer to that?
Yeah, we obtained a 3D volume. So it's the same inversion type for both the left and right atrium, but it would be interesting to check that.
Okay, thank you very much, both of you. So now I'll hand over to Zhang from Oxford, presenting our second paper, which is called Artificial Intelligence for Contrast-Free MRI Scar Assessment in Myocardial Infarction using Deep Learning-Based Virtual Native Enhancement, VNE. And I think that's very exciting because we all know about the limitation, the problems associated with contrast agents. And with mapping, we have a tool to look at tissue characteristics without contrast. But so far, there have not been any convincing papers that could show that we can replace it. So maybe this is the one. So Zhang, take it from here. Thank you very much for coming.
Thank you, Matthias, again for the invitation and for the introduction. So I'll share our latest development of AI-based CMR imaging method called virtual NativeEnhancement, and its validation on a patient, a patient with a chronic myocardial infarction. And so I'm a machine learning scientist at Oxford with a special interest in CMR and clinical applications of AI methods. So this is a joint work with Matthias. With Matt Burrage, Stefan Pichnik, and Vanessa Ferreira. So as a background, CMR late gadolinium enhancement has been the imaging gold standard for myocardial tissue characterization, including viability assessment in patients with a chronic myocardial infarction. But LGE requires the intravenous gadolinium-based contrast agent, and this introduces a few limitations. For example, increases the scan time and contraindicated in certain patient population. And
I don't know, is it just me? I cannot hear you anymore.
Sorry, it's the,
Oh, okay, good, thank
yeah,
you.
it's the, so I need to adjust the, apologize. So a native CMR, such as CNI and T1 mapping are alternative methods for cardiac phenotyping. And in particular, T1 mapping has shown promise in the contrast-free assessment of primary infarction. But the diagnostic performance of T1 mapping using visual assessment alone is currently suboptimal, and due to like a lack of standardized presentation and other confounders. So we are developing a novel artificial intelligence approach called virtual enhancement. So this technique uses deep learning to generate LG-alike images by enhancing the signals in T1 maps and the CNI images. So this technology was first validated in patients with hypertrophic cardiomyopathy, as published in Circulation last year. And in this work, we hypothesized that the further deep learning development of VNE can enable gadolinium-free visualization for myocardial scar in the assessment for myocardial infarction. So first goes to the deep learning method. I'll demonstrate this figure here. So sitting at the core of this technology is actually a group of neural networks. So the neural networks extract the information from a T1 mapping together with the CNI images, and then combine the enhanced information to produce like a VNE image that resembles a conventional LG image. So this neural networks is then trained on using like a generative adversarial network, a deep learning strategy that can encourage the neural network to produce images that looks like LGE, detect lesions like LGE. So for image quality assessment, we use the user interface for the image analyst to blindly score the image quality of LGE VNE based on these 5 categories. And then for lesion quantification, we use a semi-automated methods that's performed in the same method for VNE, the LGE. So then we derive the scar region of interest calculated using a 4-weight half maximum method. And then we calculated the scar volume fraction and the transmirality of the scar on both images. And also we asked the 2 CMR experts to assess the visual spatial agreement and the myocardial scar extent on the LG and the VNE images. So first, so in the results of the first study population, we collected patients data set from 2 groups. First one is the chronic myocardial infarction patients from OxAMI clinical list, and the second one is from the Oxford Acute Myocardial Infarction study. We used the 6-month scan after acute myocardial infarction, and then all the so the data set is then split into a training and test, and the test data set based on the CNI images. So if all CNI images that acquired after the gadolinium contrast agent, as routinely used in the clinical study and clinical practice, is used for the training of the neural networks, with the CNI images translated into synthetic pre-contrast. And all the data set with the pre-contrast CNI images and the pre-contrast T1 map are reserved for the independent testing, so that we can have a VNE imaging technique that's completely contrast agent free. And then for the image quality, we asked the 5 operators to score the LG and the VNE image quality blindly, and the results showed that the VNE has significantly better image quality compared to the conventional LG images as assessed by all 5 operators and their average score here. And also here's the few example demonstrate the better image quality for VE. So on the first row is the LG images. We can see it can be affected by the pole nulling here, and also the motion artifacts on these images. And as comparison, VE is has clearer image contrast. And then for the myocardial infarction scar size and the transmissibility assessment. So here are 4 patient examples as shown in the 4th panel. And in the first, in the top rows of each panel is the conventional LG images and also their scar region for interest. And also in the bottom row is the developed contrast-free VE images. We can see the VE detected the myocardial infarction scar with a high visual spatial agreement with the conventional LGE. And also we further derived the transmissibility plots based on the scar region of interest. And we can see both the methods detected a clear LAD infarct scar in this patient, and also circumflex infarct scar in this patient. And also there's like a infarct scar detected in multiple territories in this patient example. And then in the last patient example, there's no significant myocardial infarction scar. So on the full testing data set, so the developed VE correlates strongly with the conventional LG images in quantifying the scar size as a percentage of the LV volume, and also in the main scar transmissibility on the full testing data set. And the intraclass correlation was 0.94 for the scar size and 0.9 for the main scar transmissibility. And also we did a proof of principle histopathology validation using the dataset kindly provided by our collaborator Rohan Dharmakumar. And we can see those are the 2 pigs datasets. And from left to right, we have the developed VE images and the conventional LG image, and also the X-view slice and the histology data. We can see that the VE image correlated detected the clear infarct scar, and is correlated strongly with the LGE. It's matched strongly with the LGE and also the X-view slice and the histology data. And then as the last assessment in the results section, we have 2 CMR experts that who visually assessed the VE and LG images, and we found that overall VE demonstrated the accuracy of 84% in detecting scar when compared with LGE, and with a specificity of 100% and a sensitivity of 77%. So in discussion, so this study has several major contributions, and the last data set from patients with a history of prior myocardial infarction, VE demonstrated a superior image quality comparing with the conventional LGE, and with excellent agreement in visual spatial distribution, scar size, and the transmissibility. And also we have the proof of principle histopathology comparison, which shows a good agreement between the VE and the histology. And we believe VE represents a potential paradigm shift in CMR imaging for assessment of myocardial infarction scar, as it can allow significantly faster, lower cost, and contrast-free CMR scans with improved image quality, and has similar accuracy to the current gold standard LGE. And so there are 2 discrepancies between the 2 methods on good quality images, and this provides interesting insight to inform directions for future work. For example, that could be small subendocardial scars that can be very difficult to assess on both methods. This can be improved by potentially using larger data set of small subendocardial scar for machine learning when combined with the enhanced blood pronouncing algorithms and alongside strict quality control procedures and slice sections. And finally, we also demonstrated with a case example of real-time clinical use. So this is the patient with an episode of chest pain, and is referred to CMR for a scan for viability assessment. So we sit in the scanner room with this laptop, and while the patient is doing this routine CMR scan, and as soon we acquired the cine and the pre-contrast T1 maps, we obtained the data set and calculated the alternative enhancement images with our method, and where it reveals a clear infarct scar in the LAD territory. Then the radiographers went ahead to inject the contrast agent, and 10 minutes later, they acquired the post-contrast conventional LG images, as shown here. So on the LG images, it's confirmed there's like a myocardial infarction scar in the LAD territory, and we can also notice that the new VE image has actually better contrast and the image quality than the conventional LG images. So the study has a few limitations and pending further work. For example, we plan to extend the VE methods to the full spectrum of myocardial pathologies, and we have not directly assessed the viability and the prediction of functional recovery in this study. And in some individual examples, there might be residual edema despite being like several months after from the acute event. And finally, we aim to do like multi-center validations linking VE to clinical outcomes across a range of pathologies. And in conclusion, VE shows a promise as a transformative and paradigm-shifting AI-based technology for the future of CMR imaging. And it has a superior image quality to conventional LGE and may be applied to clinical practice in a ready and easy-to-use format, and it does not require contrast agent. And we believe this type of technology can further improve the accessibility of CMR imaging in the very near future.
Thank you very much, Zhang. And I also welcome Vanessa, the senior author of the paper. Congratulations. This is what feels like a landmark paper. So very impressive results, and there's certainly an extremely important step into the direction that MR should go: simpler, faster, and less cost intensive. Now I have there are questions from, and I'm sorry already, we'll go a few minutes over time. One question I have is, of course, a sensitivity of 77%, one may argue, okay, if I miss 1 out of 4, that's not necessarily a good thing. On the other hand, those missed may not be the clinically super important infarcts either. And we know that SPECT also misses about 80% of the subendocardial infarct. So we're already at least as good as SPECT. But do you expect that the sensitivity would increase further, or and what do you think this was based on? Because if your image quality was better, one could argue, okay, why do I, with a better image quality, miss small subendocardial infarcts?
Thank you. I think that's a great question, Matthias. So the 84%, so there's a final analyze is like personalized comparison, meaning each patient could have like quite a few slices, and this is like a slice by slice comparison between both images. And we need to keep in mind that the VE LG slice is not the exact same position, and sometimes in the same patient, VE did not pick up the infarct scar in one slice, but it can be picked up in another slice. Okay. And of course, this is pending future work that, as I've mentioned, we plan to train on like even larger data set to address the like a better detection of especially those small myocardial infarction in subendocardial infarction, and this is a pending future work.
Mm-hmm. Yeah, thank you very much.
Qiang had discussed in the discussion of this paper as to, because we scrutinized every single one of those where it was missed, and we wanted to see what the mechanism was for missing them. So some of them was because, as Qiang said, it was these very small subendocardial scars that may blend in with the blood T1, because if you have high subendocardial T1 and the blood T1 is also high, it can be quite difficult without wall motion abnormalities. So the cines are not going to help you, or the neural networks. The other thing that we noticed was that the actual T1 values may impact on how well the neural networks can deal with it. For example, if you have let's say a recent myocardial infarction where the T1 is still, quite high or something like this, or it may be in evolution, it may have pseudo-normalized, it's coming down, and you don't have wall motion abnormality to help you.
Yeah.
The neural networks may think that it's actually normal. And so here, we may need to, as Qiang said, train with more data sets, like more small subendocardial MIs, maybe with dark blood late-GAD, in some way, or we're working on the acute MI data set, because the actual T1 values, I think there's a comment in the chat, because in an infarct scar, the T1 can be high, it could be pseudo-normalized, or it could be low in chronic scars that have undergone lipomatous metaplasia. And the neural networks has to learn to deal with all these things. So it may be, a case of where it needs to be exposed to many different types of chronic MIs.
Yeah. Thank you very much. So in the interest of time, we have to keep the answers now short. For the remaining question, one is coming from Amin Amyar. She wonders, or he wonders, then how can it be that the networks create an image quality that is better than something that it had just learned to basically reimagine? So how can a method that is trained to do this something be better as that something? So
this is a great question, actually. So actually in the training, so when we train the neural networks, we train those models only on the LG images with good quality, and then we tested the methods. We tested it on the all LG images. That means when the algorithm is learned on the good quality images, it learns to produce a good quality LG, despite the real LG images in the test set is inferior in image quality sometimes. And also we noticed that actually the pre-contrast images such as scene images and the T1 map many times is at better quality, because quite at the beginning of the scan protocol, as comparison to LGE, when the patient is getting fatigue, and there might be more motion artifacts and other artifacts. So this benefits the neural networks as well to produce better image quality.
Because that to me explained it, that basically the goal of the algorithm is to get something like more the cine image and not so much the LGE image, the cine image with the information of the mapping. So then the cine images usually have a better quality, or less sensitive to some of the artifacts than the late enhancement images.
Yeah.
It's just a problem of basically co-registration that may in some cases be a problem.
And also the late GAD image, sometimes the patient, is tired by the end and they have breathing artifacts, and the cine and T1s are acquired early in the scan. So the patient, may still be quite fresh and be able to cope with that. And then the null time in late GAD can be problematic, but you don't have to deal with null time with native T1 maps.
Yeah. Also good point. Okay, last question from Javad. Does this algorithm, is that feasible for every scanner, or should it be trained for each scanner?
So currently it's trained on a data set acquired with from a Siemens scanner. So it works with a single vendor. But because the deep learning algorithm is data driven, that means we can add new training data set from different scanner vendors. And if we train with a sufficient data set from different vendors, I believe the model can work with data set from multiple vendors.
Yeah. Okay. Thank you. We had already addressed the very last question. So I think this is a very, very important step, and we're all very excited and curious to hear more about now the acute infarcts and others. So if you could unshare your screen, Zhang, and then before I let everybody go, I want to just beat the drum for the next journal club. It will be on September 7, and it will address another very important topic, which I think is so often overlooked, the really dramatic impact of myocardial hemorrhage on outcomes. And we present 2 papers as an exception. Both are from the same team around Rohan Dharmakumar. One published in Nature Communications just, I think, a week or 2 ago, and one earlier on the impact of intramyocardial hemorrhage as assessed by cardiac MR on outcome markers such as myocardial salvage and fatty degeneration. So thank you very much, everybody, for joining. And it will be, the next journal club will be as usual, same time as usual at 5 o'clock in Central Europe, 4 o'clock in UK, and 11 here at Eastern Standard. Okay, thanks everybody. Have
Thank
a great
you.
day.
Thank you,
Bye-bye.
Matthias.
And
Bye-bye
thanks
now.
for the
Thank you,
presenters.
everyone.
It was fantastic. Thank you. Bye.